Right, for those who don't know me, my name's Alan Pope. I'm the president of the branch. So it's our pleasure to have Jessica Cathart as our speaker tonight. She's going to be speaking about, you know this, of course, designing cluster randomised trials for the real world. If you didn't know that, you wouldn't be here. A few words about her. She's Professor of Biostatistics in the School of Public Health and Preventive Medicine at Monash University. I had to consult my notes for that because it's such a long title. I hope you don't have to consult your notes for each time. She was the president of the Statistical Society of Australia, that is the national president from 2020 to 2022, and before that, a president of the Victorian branch as well, before we got Tasmania as well. I won't say any more about her. I'll ask her to start.
Thanks, Alan, and thanks everyone for coming along this evening to hear me talk about some of the work that my group has been doing on designing cluster randomised trials for the real world. I'll first take a moment to acknowledge the traditional custodians of the land where we're all meeting and where this work was all done, the lands of the Wurundjeri people of the Kulin Nations. So I'd like to pay my respect to their elders past and present. Okay, so we're not such a massive group here tonight, so please feel free to stop me at any point if you've got questions, if something's not clear. No point sitting there wondering. Okay, so, and if our friends online, if at any point you stop being able to hear me or you'd like to ask a question, best thing to do is just unmute and ask that question. I might not see things if they come up in the chat. Okay, so let's see if I can progress these slides forward. Okay, so first just acknowledging my funding. I'm supported by an NHMRC investigator grant. The work presented here was supported by an ARC discovery project, and some of the future work I'm going to be talking about is going to be supported by another ARC discovery project. So thank you to the funders. The work I'm talking about has been done not just by me, but by the members of the Cluster. So we're a group of researchers at Monash Uni who look at all sorts of things to do with cluster randomised trials, designing these studies, analysing these studies, the conduct of these studies. We're there throughout the entire process of cluster randomised trials. So we've got a few of our members there. We've got a few more people in the group as well whose picture, well, I haven't updated the picture in a little while, so that's my fault. So we do have a bit of time together this evening. So just so you know where we are, where we're headed, this is the roadmap for tonight's talk. So we're going to start out talking about randomised trials and why we need to cluster in certain situations. This may be old news to some of you, in which case I hope that you'll bear with me, maybe have a little snooze, come back when we reach something a bit more interesting. I'll then be talking about extending these trials over time. So why might we need to do that? What does it mean? And then I'm going to get to the real content of tonight's presentation, designing cluster randomised trials, and some of the roadblocks and issues that we've come up against in some particular trials that we've been involved with. So we've got Scan Patient, we've got Quick Start, and we've got FebCon. All of these trials have fantastic names. I'll then touch very, very briefly on some other work that members of the Cluster are doing before wrapping up with a few final thoughts. Okay, so let's get stuck into individually randomised trials. So I'm sure many of us are aware that when a researcher, when a medical professional, when a trialist wants to know whether a particular treatment is better than the standard of care, whenever they want to compare two treatments, they'll conduct a randomised trial. Hopefully they'll conduct a randomised trial. So usually what will happen is individuals will come into the study, they'll be assessed for eligibility, they'll be recruited to the study, and then they'll be randomised either to the control or to the intervention condition. Randomisation implies that any difference we see between these two groups at the end of the day is due to the difference in those treatments and not due to any other underlying characteristics, provided randomisation has been appropriately conducted and we've got a large enough study and all of these caveats hold. But in any case, individual randomization is the gold standard for assessing the effect of interventions. So this is what we would ideally like to do in every single case. But it's not always feasible, not always possible. Sometimes, instead, we need to randomise entire groups or clusters of individuals. So these clusters could be hospitals, so all of the patients in a hospital. They could be intensive care units, so patients within an intensive care unit, schools, students within schools or within classes in a school, or they could be neighbourhoods, so people living within neighbourhoods. I'm sure you can think of other examples of clusters that we could be considering. So a cluster randomised trial looks like this. So we've got clusters now being randomised to our control and our intervention condition. So everyone within, let's look at cluster 1 here, all of the individuals within cluster 1 receive that control condition. All of those individuals in cluster 3 here receive the intervention. So that's what a cluster randomised trial is. We're randomising the clusters, but we're still taking measurements on these individual participants. So why might we need why might we need a cluster randomised trial? Well, there are a few reasons. One reason is that the intervention is applied to entire clusters. The example I always pull out for this is looking at new methods for cleaning hospitals to prevent hospital-acquired infections. So whenever a patient goes to hospital, there's always a risk that they'll pick up some nasty bug and have to be treated for that. So golden staph is a good example. So hospitals work really hard to prevent these sorts of things from happening. And one of the ways they might try to prevent patients getting these nasty bugs is to upgrade their cleaning programs. So have a new process for cleaning hospitals, cleaning the wards. So here, what the researchers might want to know is whether this new program does better than the old program for preventing these hospital-acquired infections. So do we get fewer infections when we use this new program compared to the old? But here we can't randomise these individual patients. We can't. There's no way we can tell one patient, well, we're going to clean you and the space around you in this way, but this other patient, we're going to do something different. It's just not going to work. In this case, the intervention is applied to the entire cluster, to the entire hospital, so we need to randomise the hospitals. Another reason why we might need a cluster randomised trial is that the risk of contamination is too great in an individually randomised trial. So what do I mean by that? I mean that if one person receives the intervention, then the people around that person also get some benefit of the intervention for whatever reason. They could be members of the same family. They could all be treated by the same clinician, for example. So there has been some work that looks at how much contamination an individually randomised trial can bear before you need to turn to a cluster randomised trial, but that's not what I'm going to focus on today. So another reason we might need a cluster randomised trial is just because applying the intervention at the cluster level is more logistically feasible. And here I turn to the example of the intensive care unit. So patients in an intensive care unit, well, they've got a lot going on. Intensive care units are busy places. The doctors and nurses who work in an intensive care unit are very busy working on all of these patients within them. If we've got some sort of individual level treatment that we could apply to the individual patients within an intensive care unit, it's going to be really difficult for the doctors, for the nurses, for these clinicians to switch over treatments between successive patients who come into the intensive care unit. So instead, we might just decide to randomise the entire intensive care unit. All patients in the intensive care unit get this treatment. All patients in that intensive care unit get the other treatment. Okay, so these are some reasons why we might conduct cluster randomised trials. So what's the problem with them? We know that they're necessary. We know why they're necessary. Let's just conduct cluster randomised trials. The issue is that the outcomes from individuals in the same cluster tend to be more similar to each other than outcomes from individuals in different clusters. So the individuals who are in the same cluster, so think of patients in the same hospital, for example. They might be treated by a similar set of clinicians. Well, they will be treated by a similar set of clinicians. They might have similar characteristics. They might be being treated for similar conditions. they've got a shared environment. So this is going to lead to more similar outcomes for these patients within the same cluster than between clusters. We need to account for this within cluster correlation when we design and analyse these trials. We don't have as much data as we think with these cluster randomised trials. We don't have as many independent pieces of data as we would for an individually randomised trial because of these shared environments that we're considering. So we quantify the intracluster correlation using, well, we quantify this correlation using the intracluster correlation, which we often denote using the Greek letter rho. So what is the intracluster correlation? Well, it's just some function of the covariance of two individuals from the same cluster and the variances of those individuals' outcomes. Okay, so what is rho? What does it look like? I'm sure pretty much everyone in this room will know, have had experience with an intracluster correlation with a correlation coefficient. But just to make sure we're all on exactly the same page with that, the intracluster correlation, well, I'm going to tell you now it's a number between 0 and 1. It's actually a number between -1 and 1. But in the situations that we consider, we don't really see negative intracluster correlations. So a negative intracluster correlation means that two individuals from the same cluster are less similar to each other than two individuals from different clusters. And that's not something we really see in health applications. Okay, so for our purposes, the intracluster correlation is a number between 0 and 1. 0 means we've got complete independence between any individuals in the same cluster. So it doesn't really matter that they're in the same cluster. It doesn't have an impact on anything. And 1 means that we've got complete dependence. So all of the outcomes for our individuals in a cluster are identical. This is the space I usually work in. The intracluster correlation is somewhere between 0.01 and 0.25, somewhere in that region. Doesn't seem like a big deal. That's not a big number. Well, even this small number can have a big impact on planning these studies. So if we want to conduct one of these studies, we need a sample size calculation. We need to know how many clusters, how many individuals we need in order to detect an effect of a size that we're interested in with a given level of power. So in order to work out how many individuals we need for one of these cluster randomised trials, we would take the sample size we need for an individually randomised trial and multiply it by this number here, 1 plus m minus 1 times rho, where m is the size of our clusters. So you can see that if m is moderately large, we're going to be inflating that sample size quite a bit. And I have a bit of a demonstration of that inflation for you here. So there's a fair bit going on this figure. So let's step through it a bit. On the x-axis, the horizontal axis, we've got our cluster size from 0 up to 200. On the y-axis, the vertical axis there, we've got study power. Now, we like to target a power of 80% because why not? We could discuss why we do these things, but now is not the time. We want a power of 80%, so we want to cross that purple line there. Okay, so this study, we've got 20 clusters in each of our two arms. So we've got 40 clusters in total. We want to detect an effect size, the number which I have forgotten. If our intracluster correlation is equal to 0, then, well, we need probably around, 35 or so individuals in each of these clusters in order to do this with the power level that we're interested in. If our intracluster correlation is 0.01, then we need 55, 60 individuals in each of these 40 clusters to do that. What if our intracluster correlation is a tiny bit bigger, 0.05? This is not an unusual number. Well, now it doesn't matter how big our clusters are, we are never going to have sufficiently large power to detect our effect of interest. We are going to need to find more clusters or do something different. We just can't. We can't perform this study. We're not going to have a reasonable level of power given these parameters. Okay, so what can we do?
Sorry,
yes, Dennis.
Two messages in chat. Just wanted to make sure that.
Okay, let's see. 2 new messages.
Okay, they're good.
Good.
Yeah.
All right. Thank
Yes.
you. Thanks.
Send in the chat.
Good stuff. Yes. Okay. All right. So what this figure has shown us is that the larger this value of rho, the more individuals we need, the larger our cluster sizes need to be. But we've also seen that sometimes, well, we always get these diminishing returns. Beyond a certain point, adding more individuals to a cluster doesn't increase our power very much. And sometimes we're never going to get the power level that we want. We're going to need to add more clusters to our study instead. But what if we can't add any more clusters? So I'll turn again to intensive care. So in intensive care, how many intensive care units are there in Australia? Well, there's quite a few. I'm not sure of the exact number, but it's at least 50. Not all of them are interested or able to participate in research. Okay, we want to run a trial in intensive care medicine. We want to try and save more people's lives. Maybe we've got 30 clusters, 30 intensive care units who could participate in the study that we're interested in planning. That might not be enough clusters. We can't build more intensive care units. I mean, we probably should be as a nation, but we can't add more clusters in this situation. So what can we do instead? Well, this is where extending trials over time becomes valuable. So longitudinal cluster randomised trials can help us in this situation. So in this study, this class of study designs, clusters are followed over time and measured repeatedly. The participants within these clusters, they might appear just once in one period of the study, or they might come back multiple times. That's not really an important issue here. We're going to just suppose, for the purposes of this talk, that each individual just appears once in the study. Each time we look at the cluster again, we've got a new set of individuals, but that's not an important issue. The key issue is that clusters may switch between the control and the intervention conditions. This is what is valuable. This allows us to make comparisons not only between clusters, but also within clusters. And it's these within cluster comparisons that we can make that lead to increases in power and reductions in our required sample sizes. So let's look at a particular study design. So here I've got a cluster randomised crossover trial. So now, instead of clusters being randomised to implement the control or the intervention, which I've conveniently labelled treatment A and treatment B here, so instead of randomising clusters to treatment A or treatment B, clusters are now randomised to a sequence of interventions. So clusters randomised to sequence 1, they start off with treatment A, switch over to treatment B. Those randomised to sequence 2 go the other way. So now we can make comparisons not only between our clusters in each of these sequences, but also within our clusters. Each cluster acts as its own control, and this leads to gains in power. We can look at the inflation in sample size required for one of these trials, and we've got a really nice simple formula here. So if we've got a cluster randomised crossover trial, we need to inflate the sample size we would require for an individually randomised trial by the amount we would need to inflate given the cluster randomised trial, but then we multiply by this additional factor here, 1 minus rho times R. So this is another intra-cluster correlation. I'm not going to go into the details. It's another number between 0 and 1. So we've got 1 minus a number between 0 and 1 divided by 2. So this number is going to be less than 1. So we're deflating that required sample size. So we're kind of getting back some of the power we lost through clustering by getting clusters to switch over. Now, something to note is that cluster randomised crossover designs are only possible when we can switch back and forth. That's not always going to be possible. If we're teaching clinicians, say, some new way to, I don't know, treat patients with knee osteoarthritis, we can't tell them to forget everything they've learned the next time a new patient comes in. That's just not going to be possible. So this sort of design, incredibly powerful, but only useful in a limited set of situations. So what can we do otherwise? Well, there are other sorts of trials we can consider, other designs. So here I've got the stepped wedge cluster randomised trial design. So this is one example of a stepped wedge. So now, again, clusters are randomised to a sequence of treatments. Here we've got a 3-sequence design with 4 periods. All of the clusters start out implementing the control condition. Over time, all of them will switch over to the intervention until in the final period, all of the clusters are implementing that intervention. So this is useful when we're looking at those sorts of treatments, those interventions that can't be undone, that we can't take back, that we can't tell people to forget. Or if we're looking at something that's going to be rolled out anyway, this is a really useful design because everyone gets that intervention by the end of the study. Once again, we can come up with one of these handy formulas for the required number of participants we need. And it looks like this, a bit less interpretable, I'm sure you'll agree. But once again, this number is usually less than 1. So once again, we are getting back some of the power we lost through clustering with these crossovers. Okay, so now that's all background. That's everything you need to know for what I'm going to actually tell you tonight. Some work we've done on designing cluster randomised trials. Okay, so in my job, I work with a lot of researchers who are really keen to know how to improve the health and well-being of people. So it's pretty amazing. Like, these people get up in the morning and they think of how they can help people, which it's really wonderful to get the opportunity to work with these people. They often consider cluster level interventions, and I've got some examples of the cluster level interventions that I've been involved in considering here. So a new way for radiologists to assess pancreatic cancer scans. We'll return to this example in a moment. A public information campaign telling people what to do if they experience chest pain. We want people to call an ambulance if they experience chest pain. Can we get more people to call an ambulance if they experience chest pain by a public information campaign? And in a new model of delivery, for delivery of preconception care. So how can we help GPs deliver care to people who want to become pregnant? So when people are interested in things like this, they come to me for statistical advice. And the question they ask me is, how many clusters do I need? And I always say, well, it depends. Of course it depends. We know it depends. It depends on a lot of things. It depends on how much they want to change that outcome by. It depends on the desired level of significance and power, but these are usually 5% and 80%. As I said before, we're not going to discuss issues to do with hypothesis testing here. It depends on how much correlation is induced by clustering. So that intra-cluster correlation parameter that I mentioned. And we can make that more complicated as well. I'm not going to talk about that tonight. And it depends on the design itself. So are we looking at one of these standard cluster randomised trials, a cluster randomised crossover trial, a stepped wedge, something else? So what we do is we assume a model for the outcome. Theta is our treatment effect. We've got an estimator for that, theta hat. So if we've got a linear mixed model, we'll have just a generalised least squares estimator at the stage of planning the study. And the variance of theta hat, well, this is the variance of our treatment effect estimator. This number depends on the correlation, the amount of correlation induced by clustering, and the design itself. So we can work out what that looks like for any design that we're interested in. The number of clusters we need is then a function of the effect of the intervention on the outcome, the desired significance level and power, and this variance of the treatment effect estimate. These are the ingredients we need for those sample size calculations. This will tell us how many clusters we need.
What about 3? Why does it depend on 3?
So the variance of the treatment effect estimator depends on 3 and 4. So it does depend on all of these things, but we only care about how much correlation is induced by clustering and the design itself through this function of the variance of the treatment effect. Okay, so what happens then? Well, then, together with these trialists, we put together an award-winning grant proposal. We get our money to perform the study, and then we run into issues that delay progress. So we've done everything right up until this point, but then once we try to actually conduct this study, we find that recruiting clusters is actually really difficult. Not through anyone's fault, just because clusters are busy. Ethics procedures and governance procedures take a really long time to get done. And everyone's overworked anyway. Okay, so recruiting clusters is really difficult, which means that these wonderful designs that we've considered might not be feasible in practice. And this lack of feasibility has led to some really interesting difficulties, leading to new trial designs and what I think are some really interesting results. So let's talk about scan patient and batch step wedge designs. So scan patient is a trial looking at synoptic reporting of CT scans assessing cancer of the pancreas. So patients with pancreatic cancer is a really difficult and deadly disease, and whether the prognosis of patients, how long they will survive for, depends on whether or not their tumour is operable. Now, the pancreas is a really complex organ. A lot of stuff is going on there. It's really difficult to tell if a pancreatic cancer tumour is operable. Radiologists have to really carefully assess these CT scans. So in order to help radiologists do this, a new synoptic report was developed. The trialists I work with wanted to know whether this new synoptic report, does it actually lead to better identification of operable tumours and better patient outcomes? So we planned a step wedge trial, rolling out the use of this report across hospitals in Australia. And this is the step wedge trial that we planned. So it's a 3-year study. We've got 40 hospitals. Every 6 months, 8 hospitals will cross over from the standard way of doing things to this new synoptic report. Wonderful. So one of the things we need to note, and I'll just go back here, one of the things we need to note about step wedge trials is that all of the clusters need to get started at the same time. We've got a complex interplay between time and treatment here, which means that in order to actually know that any difference we observe between groups is due to that treatment, we need to be measuring all of these hospitals over the same period of time. Everyone needs to get started at the same time. Now, the scan patient team were very well aware of this. They worked incredibly hard to get all of these hospitals ready to go, but it just didn't happen. The process was even more difficult than they anticipated. Some hospitals were ready to go well in advance of others. And there was a risk that if we waited for all of the hospitals to catch up, that those who were ready to go would just throw up their hands and say, well, we're not interested anymore, you've taken too long. So at one of our regular trial meetings, they asked me, well, Jess, can we just get started with those hospitals that are ready to go? They're ready to go, let's just go. And my answer was, well, let me think about this. My actual answer in my head was, no, that's not possible. But I thought, I'm going to deliver that in an email rather than on this Zoom call because I don't really like confrontation. Anyway, I did think about it. Standard cluster randomised trials often randomise clusters in batches. So in standard cluster randomised trials, it's not uncommon for us to get a few clusters together, randomise them to control the intervention, and then find the next clusters and keep going on. So can we develop some theory for batched variants of the stepped wedge? So of course, this is the standard step wedge design. We all know and love it. I already told you that all clusters have to start participation at the same time. A batched variant of this design would allow clusters to be recruited as the trial continues.
So what does the at the same time do? Why do we have to insist on that?
Why do we have to insist on that? Okay, so you'll see here that over time, as time progresses, we've got more clusters switching over to the intervention. So we've got confounding of time and treatment here. So if there is something going on over time which is impacting the outcome, we hope that our intervention is also impacting the outcome. So we've got time has an impact on what intervention clusters received. It also might be having an impact on the outcome. So we've got this confounding effect of time. So in order to adjust for that, we need everyone measured at the same time. We want to make these comparisons in each of these periods. That's a great question. Thank you. So we need everyone to get started at the same time. A batch step wedge design would look a little bit like this. So here we might have a few clusters ready to go. We randomise them to the sequences of this first batch. While things are progressing in that cluster or in that batch of clusters, We recruit a few more clusters, randomise them to the sequences of this next batch, and so on and so forth until we've got all of our clusters. It's a sequence of self-contained stepped wedge trials. Clusters can be randomised to the next available batch, to the sequences of the next available.
You drop the first batch?
So we follow that batch of those clusters for the amount of time that is specified by the design. So after those clusters finish, thank you very much, they're gone. Now, in this study, we've got complete separation in time of these different clusters, of these different batches of the study. That's not necessary. Here's an equally good batch stepped wedge design. So now the second batch of clusters, they were ready to go after 3 periods. So we've got some overlap in time here. Another alternative would be here, where we're even faster. We're recruiting clusters even more quickly here. And then we might have something like this. So here we can recruit our second batch of clusters really quickly, but then it turns out there's a bit of a delay to get our third batch of clusters together. So with these cluster randomised trials, with these stepped wedge designs, so suppose we've got one of our clusters finishing in that first batch, we can't then take that cluster and re-include it in this later batch here because they've already received the intervention. That might have been related to what you were asking, Inga, but maybe we can chat about that at the end. Yes?
We have batches of the cluster size of 1.
No, you cannot, because we always need to be able to compare our clusters to someone else. So if we just had one cluster, so apologies to the people online, hopefully you can still hear me if I move over here. I'll use my mouse. So if we just had one cluster, that cluster would be randomised to one of these 3 sequences, right? So if we just imagine we've just got this first row here, 0, 1, 1, 1. So now, okay, yeah, we can see if there was a change between this period here and the next period for that cluster in terms of outcomes. But we don't know if that's just because there was a change over time.
Okay.
There's no randomisation. We need a comparator.
And is 2 okay? Or do you run into issue the sample size? Do we have to insist that the number of clusters in a batch is large?
Not necessarily, no. So we don't need to insist that we've got a large number of clusters in the batch. The number of clusters in a batch depends on how big these stepped wedge component designs need to be. And we would use our sample size calculators to work out exactly how many, what these batches need to look like, essentially, in order to get sufficient power to detect our effects of interest. Okay, was there another question? Okay, all right. So how do we calculate power for these batch stepped wedge designs? How do we work out what these batches need to look like? Well, as for standard stepped wedge designs, we've got to account for this clustering. We recommend separate period effects for each batch. So this is a technical point. I'm not going to spend too long dwelling on that, actually. But the point is that if we make these assumptions, power is going to be unaffected if we've got an unexpected delay before the start of the next batch. In fact, if we've got the identical batches, our batches don't need to be identical, but if we do have identical batches, then if we've got, again, theta is our treatment effect of interest, we've got the variance for the effect estimator for one batch denoted by var 0 theta hat, then the variance of the overall treatment effect estimator, so for the entire batch stepped wedge design, is just some function of these individual variances for each of these individual batches. It's the average of them, in fact. So what all of this means is that this batch stepped wedge design, this batch stepped wedge design, this one, and this one all have the same power to detect the effect that we're interested in. And that power is the power of the design of one of these component designs with all of the clusters randomized to those sequences. Batch stepped wedge designs are great because we don't require that all clusters get started at the same time. We've got some time to get things sorted out in clusters as we go. But we still have that randomised rollout across all of the clusters. And our power and sample size calculations can be very straightforward for these designs. Study power is robust to delays with batches, which is wonderful. So we've got a stats in med paper where you can find out all of the details. Scan patient, what happened with scan patient? Well, scan patient is being conducted as a 3-batch stepped wedge design. So this is what scan patient is looking like. Okay, moving on now to quick start. So the quick start study is looking at patients with hepatitis C. So this is a disease that affects the liver, but effective treatments are available. You can get cured of hepatitis C if you take the right treatment. However, getting people to take these treatments can be a bit difficult. So the researchers I was working with wanted to know whether same-day testing and treatment leads to better treatment uptake. So if patients come in, we test them for hepatitis C using a rapid antibody test, and that comes up positive, we give them a starter pack of medication for their results. Is this going to lead to higher rates of hepatitis C cure? So the actual design that we considered was a bit more complicated than what I'm going to talk about. I'm going to talk about a simplified variant where we've got our control condition, usual care, and then this testing, rapid testing and treatment for patients with hepatitis C who come up as positive for hepatitis C. So a cluster randomised crossover trial was planned. So we've got these treatment centres that treat people who inject drugs. People who inject drugs are more likely to have hepatitis C than the rest of the population. So these treatment centres were randomised to a sequence of intervention conditions. And these tests and medications were supplied to the centres as appropriate. So this is the quick start study for the purposes of our talk today. So here, 10 treatment centres start off with doing what they usually do, and then they get given all of these antibody tests and starter packs of medication. The other 10, they get given all that stuff first, and then they switch over to their usual standard of care. So here we can switch back and forth between these intervention and control because we're giving the centres all of this stuff. Clusters can be recruited and randomised as the trial progresses because here, with this design, well, we no longer have confounding of time and treatment. The probability that a cluster is treated at any time point is 50%. Okay, in any case, trialists knew that recruiting treatment centres was going to take time and effort, and we always planned to conduct the study in batches. However, cluster recruitment was even more difficult than anticipated. I'm not sure if the rest of you remember what happened in 2020, but the people who ran this study sure do. They had a lot of trouble with cluster recruitment. However, once they had recruited clusters, some of those clusters who were involved in the study, they loved it. They wanted to stick around. So, at one of our regular trial meetings, the question that I was asked was, well, can we include some clusters in the trial a second time? They had a great time the first time. Can we just include them again? And of course, my answer was, well, let me think about this. And of course, that really meant no. But again, I did go away and think about it. And so the theory for designs where individual participants are included in a trial multiple times has been developed. There's that theory out there. So these sorts of studies are really useful if you're dealing with episodic conditions. So for example, migraine. So someone who has a migraine, usually people don't just have one migraine in their life, they have a few migraines. So if a patient has a migraine, we could randomise them to one of any number of treatments. They go away, they get better more quickly or not. The next time they have a migraine, well, we could re-randomise them to another treatment. So this sort of thing is possible when we've got participants who fulfil our eligibility criteria multiple times at each subsequent inclusion. So can we extend that to cluster randomised trial designs? Okay, so let's think back to what cluster randomised crossover designs actually are. They're useful when we can switch back and forth between treatments. Incredibly powerful. So a re-randomisation cluster randomised crossover design would allow clusters to be re-randomised potentially multiple times. So what do I mean? So let's consider a cluster. Our cluster enters the trial, they get randomised to one of these two treatment sequences. Let's suppose they've been randomised to the first treatment sequence. At the end of that, they might decide to leave the trial. Thanks very much, leave us alone. Or they might say, we had a great time, we'd like to be included again, in which case they could be re-randomised and randomised once again to one of these two treatment sequences. And the same for our clusters who were originally randomised to the second sequence. They might leave or decide to be re-randomised. Okay, so what happens when we re-randomise clusters? Will the variance of our treatment effect estimator, remember this is what we need to do these sample size calculations, this tells us how many clusters we need for a study. Is this going to increase, stay the same, or decrease? Now I'm not going to, there's only one person in this room who I would expect to know the answer to this, and that's one of my co-authors on this paper. I'm not going to ask him, just in case he gets it wrong, because that would be very embarrassing. But it turns out that the variance of the treatment effect estimator is never going to increase when we re-randomise clusters. The variance is going to stay the same or decrease. What does this actually mean though? This means that re-randomisation, repeatedly including these clusters, is never going to decrease your study power. You're never going to do worse if you include another cluster again, or if you go out and get a new cluster. Sometimes we might not do any better. Sometimes it might be equivalent to go out and get a new cluster or re-randomise our same cluster. But in many situations, we are going to do better. We are going to have gains in power when we re-randomise new clusters. Oh, sorry, when we re-randomise existing clusters instead of recruiting new clusters. Okay.
So my question
would then be when can we improve, when can we not?
Okay, so if your original study is a parallel cluster randomised trial, so just a standard cluster randomised trial, where clusters are randomised to the control or the intervention, if after that we re-randomise clusters that have been included, we are always going to do better. And the reason for this is now in this repeated inclusion study, we've got an opportunity to make within cluster comparisons. We didn't have that before for the original study. So now when we re-randomise clusters, some clusters are going to start off in the control condition and switch over to the intervention condition at their next randomisation. Bam, we've turned our standard cluster randomised trial into a cluster randomised crossover design, which we know is more powerful. In the case of cluster randomised crossover designs, things are a little bit more complicated, and it depends on how we expect these within cluster correlations to change over time. If there's no change over time in that correlation, then it's not going to make a difference. If there is a reduction in that correlation over time, then we want our control and intervention conditions to be close together to each other in time, and re-randomising is going to lead to increases in study power. Bit of a technical point, but it's going to happen in these certain situations. Yes? Mm-hmm.
So the variance, the three clusters, when you say improve, does it compare the new cluster to the old cluster or the average?
So talking about these re-randomised, yep. So here, if we've got two studies with the same total number of measurements, so we've got two studies, one of which we've just got entirely new clusters, and the other one where we've got the same number of measurements, but we've included some of those clusters multiple times. So we've got fewer clusters. So then we're going to do, well, we're never going to do worse than over here, and we might sometimes do better.
So the existing and the ones that you put hold.
Yes, we include everyone together in this study. We analyse all of these clusters together, and we account for the fact that we've got these multiple randomisations.
Yes.
Yes.
With the re-randomisation, will you have an impact because you're more likely, you can have enthusiastic clusters that compliance with the interventions.
So this is what we call future work. But you're absolutely right. Why would some clusters decide to be included? Again.
This was easy, they had no difficulty doing it, they got better outcomes for their patients.
Exactly.
Made their life.
Exactly. If for those clusters who are included again, we get on average a better treatment effect, what impact does that have? Here I'm assuming that it's exactly the same for those clusters that have been included once and included again, that treatment effect doesn't change no matter how many times you're included. But if we're in that situation where, okay, well, what if those clusters who decide to come back are somehow better at delivering that intervention, their patients get better outcomes? What impact does that have? I don't know. Future work. But a great question, thank you. Okay, what time is it? We don't have much time left. I'm going to whiz through FebCon. So FebCon was a trial looking at febrile convulsions in children. So when children have a fever, they can experience these convulsions. So they go all floppy, it's not nice, but they usually recover from it, no problems. So the trialists I was working with wanted to know whether recommending to caregivers that they give their child paracetamol or ibuprofen would reduce the risk of another one of these convulsions in the same illness. So here they were rolling out this delivery of this updated guidance across paediatric emergency departments in Australia and New Zealand. Okay, this is FebCon. Looks very similar to another trial we've already seen. Looks very similar to the scan patient, and it is. We've just got a few fewer clusters here. So we're rolling out this updated guidance across emergency departments, hoping to reduce the number of kids who have more than one of these febrile convulsions in the same illness. Okay, the problem with FebCon is that some of these emergency departments are located in the same city. And the way that, my understanding, the way that training works for doctors is that they'll get rotated through multiple departments. So here we may have some staff delivering the updated guidance, or in a cluster that's delivering the updated guidance, and then they switch over to a cluster that isn't delivering that yet. Are they going to bring some of that knowledge with them? Are they going to contaminate the treatment effect? Okay, so the question that was asked to me in a meeting was, well, should we make sure that the sites located close together in space switch over to the updated guidance close together in time? And once again, I said, well, let me think about this. And this is very much work in progress at this stage. So I was thinking about this. What is going on with our clusters? So let's suppose we've got a situation like this. So suppose we've got 4 clusters here. So these would be our cities. So we've got 4 cities. In each of these cities, we've got 2 emergency departments. So 2 subclusters within each city. If we randomise those clusters, those subclusters, those emergency departments independently, we could end up with a study like this. So here it turns out that subcluster 4.1 switches over to the updated guidance first, and so on. So here you'll see that we've got subclusters of cluster 1 switching together close in time. That might be okay. That's kind of what we want. But at the same time, we've got subclusters from cluster 4 switching at opposite ends of the trial. This might not be okay. Can we restrict our randomisation? Could we do something like this? First, randomise the order of our clusters, and then within each cluster, randomise the order of our subclusters. Something like this. This would ensure that our subclusters switch over to the updated guidance close together in time. The question we would ask is it worth it? Do we need to go to this level of effort? Can we just randomise our subclusters independently? Under what conditions is that okay? So this is work that Dr. Reese Bowden, who happens to be in the crowd, is working on at the moment. So these supercluster stepped wedge designs, where we randomise certain groups of clusters close together in time, ensures that these subclusters will implement that intervention at similar time points. So this will, in the case of FebCon, help to minimise the impact of staff movement on the estimation of the treatment effect. And it may also have the added benefit of making the rollout of the intervention more feasible. If we've got this contamination issue, then it turns out that what some of the work that Reese has done has shown that we do get a more precise estimate of the treatment effect if we do randomise those subclusters to adjacent sequences. Very much work in progress, still working out exactly what this means and the boundaries on this statement. So, FebCon, we've decided to ignore the problem and just randomise clusters to sequences. We'll see if that comes back to bite us, but I think it's going to be fine for this situation. Okay, very, very quickly, I wanted to talk a little bit about some of the other work that members of our group are doing. The first thing I wanted to highlight is some of the work that Ehsan, who's also in the crowd, is working on as part of his PhD. So Ehsan will actually be submitting his PhD very soon, so that's very exciting. So we've got a stepped wedge trial here, a lot of information, a lot of clusters collecting a lot of data, collecting data for that entire treatment duration. Now, what we've got down here is an indication of how much information is being contributed by each cluster in each period of that study. So you'll see we've got this information-rich band near the time of the treatment switch. So what Ehsan has done is look at whether we can iteratively remove some of these low information content cells of the design to come up with something that's just as powerful statistically, but is less burdensome. And this is one of the designs he's come up with. So it's a bit of a strange design, but it's powerful, it does the job. You can read more about that in that paper there. Highlight the work of Dr. Kelsey Grantham, who's looking at staircase designs. So staircase designs just take that band of cells near the time of the treatment switch out of the stepped wedge design. So, of course, we are collecting a lot less data with a staircase design compared to a stepped wedge. When can we modify the staircase to make it just as powerful as the stepped wedge? Can we get a few more clusters? Can we increase the number of participants in each of those cluster periods? What can we do? So Kelsey's been working on that, and you can read about some of her work at that paper there. Okay, something else that we're working on is building flexibility into stepped wedge trials. So I talked a lot about this batched variant, about these re-randomization designs where we're recruiting new clusters, we're changing things as we go. How can we build adaptive variants of these studies? How can we take the information we have at a certain point in time, say after our first batch has been concluded, and use that to inform what our future batches look like? Tell us about how many clusters we need, how many individuals we need, how can we modify the design given all of this stuff? So adaptive stepped wedge trials or adaptive batch stepped wedge trials. This could be you. If you're looking for a postdoc position, come join us. Okay, final thoughts, second to the last slide. Cluster randomised trials have some really interesting challenges. It's been so much fun working on this stuff over the past few years. I think that where we can develop designs and statistical theory that aligns better with practice, we should be doing that. We should be working to make things easy for people. Doing this is great for everyone because, I mean, the clusters are happy. They get a trial that's been designed with them in mind. The trialists are happy because they've got designs that are more feasible. Perhaps most importantly, though, the statisticians are happy. We get some interesting new problems to work on. And then when we finally get that data from that trial, we can analyse it with confidence. We've got a trial that's more likely to go according to plan. We don't need to get distressed phone calls or emails from our trialists asking us what to do because so many clusters haven't been recruited yet. This has happened, that has happened. Okay, so I said come join us. So these are pictures of us and our collaborators at various exotic locations: London, Birmingham, Bordeaux. Bordeaux was actually very nice, and so was London. Birmingham was great too. I'll soon be advertising a 3-year postdoc position. So if you are interested in this stuff, please don't hesitate to send me an email. And we've got plenty of projects for PhD students. All right, I'll end it there. Thank you very much.
We can take some questions from the online, first from the online audience. Do you have any questions? for the guys on Zoom.
Everyone's probably having their dinner right now.
What about the ones in this room? Do you have any more questions?
Got someone whose hand is raised.
Oh yeah. Veal. Maybe you click veal to see what happens. Oh yeah.
Kim here.
Yeah, we can hear you.
I was going to ask the question, with these step wedge trials, what are your insights into potential for bias due to when the intervention is applied that there's a learning effect as period goes along?
No, this is a great question. So with step wedge trials, what have we got a learning effect as things go along?
Yeah, or learning, or even going backwards. If the first week you do it great. So it could go either way.
Yeah. So what if that treatment effect changes over time? Well, something we often recommend is including an implementation period in these studies. So, for example, if we consider this design here, instead of switching immediately over to the intervention, we would have a break where that intervention is implemented in the study to help get everyone up to speed. But then what if we do that and there's still some sort of time varying treatment effect? There was a really interesting paper a couple of years ago now by R.V. Kenny and his co-authors looking at just that problem. And it turns out that if we do have a time varying treatment effect for step wedge designs and we don't account for it, we can get some really weird results, just absolutely unintuitive results. So it is a problem. It is something that you need to be aware of and consider. Thank you.
And the immediate thing I thought I would do, I mean, this has got huge analogues with traditional experimental design, is in those situations, my immediate thought would have been just to actually have a period before the intervention and a period after and not keep going because of the risk of that bias. That would be my immediate thing if I was thinking about designing. I just wonder what your thoughts about that.
So this is thank you for that. That is actually something that Kelsey is planning on looking at pretty soon. So these staircase designs that I'm showing you here, that might be a more appropriate choice when we do have these time varying treatment effects. So if we do have that sort of thing going on, can we build a design that gets us the estimate of the effect that we're actually interested in and not some longer term effect? Yeah, thank you.
Any more questions from the...
I actually have one, but I wonder if others have any questions. Oh yeah.
Thanks for the interesting talk. I was wondering, when you said it's difficult to get the Hep C patients to take their treatments, why is that difficult?
It's difficult often with hepatitis C. So I'm not a clinician, so this is my understanding. So please do take what I say with a grain of salt. So in these populations, in order to receive treatment for in general, in order to receive treatment for hepatitis C, usually what happens is you need to have a blood test to confirm that you've got hepatitis C. So you have your blood taken, and then you come back at a later date, your hepatitis C is confirmed, and then you receive your treatment. So often what happens is people get lost. They have their blood taken, they don't come back, or they don't come back within a sufficient amount of time. They don't get their treatment, and therefore the virus isn't cleared. So that's one of the issues here.
So
Behind you, Dennis.
Thank you. So one of the things that so I work for the Australian Bureau of Statistics. So I'm an official statistician, and one of the things that's kind of struck me about your talk is the variation between kind of different statistical subdisciplines in terms of what potential biases we account for and what biases we assume away. In official statistics, one of the biases that we're really concerned about is non-response bias. So, for instance, if you're doing a survey of people or households and asking them questions about their income, and if people with lower incomes are less likely to respond to your survey than people with higher incomes, you're going to get income statistics that are biased upwards. And
So an example of missing not at random.
yes, an example of missing not at random. And there are various methods that you can use to resolve this, many of which boil down to taking into account information that we have available for a larger amount of people. So we might take into account administrative data, we might take into account data that was available from a census that has much higher sort of response rates. But I noticed that, and maybe I'm generalizing a bit here, but I noticed in your talk that this doesn't seem to be something that you're sort of concerned about addressing for your particular sort of research that you've presented today. And I'm wondering, is that because, so I've got two questions. Is that because non-response bias, because of missing not at random, is something that's of less concern to clinical trial statisticians? My second question is, how would you go about extending your methods here to non-response bias? Because, at the ABS, we would be very concerned about non-response bias, even if we had response rates of, say, 70%. I don't know what the response rates you get, but I imagine you've mentioned that it's very hard to get people in clusters to respond. So I'm very interested in your thoughts on that, because I don't have much experience with this sort of statistical subdiscipline. So thanks.
Okay, so of course we always want to ensure that we get a representative sample of clusters. So you're asking about, there are a few different layers to missing data that we can investigate here. So let's start off with the top layer. So we want to run a trial on a set of clusters that represents the general population of clusters that we're drawing from. Okay, so I did mention it's difficult to recruit clusters for these studies. So those clusters that we recruit for our studies, we know that there's going to be something particular about them. And I think that in biostatistics, this is a potential source of bias that is often, brushed under the rug. Like we don't think too much about it, but we should. We do want to think about this representativeness of what's going on, of our sample. So in certain situations for these studies, we do get all the clusters that we want. We approach clusters, the clusters are involved. But of course, there are situations where we send out, letters of invitation and clusters just don't respond. So this is, of course, leads to the generalizability of our results. Which clusters are our results generalizable to? We need to bear that in mind. Then we've got the issue of missing data at the individual level. So within our clusters, we often will be recruiting individuals in those clusters and measuring outcomes on those individuals in those clusters. So we'll put aside the issue of cluster representativeness for now and just focus on individuals. So we could have missing data at the individual level. So which individuals within these clusters are actually going to respond to whatever mechanism we're using to collect our outcome data? Well, we don't know. We do account for this using various techniques to deal with missing data. So a popular technique is, of course, multiple imputation. So we multiply impute our missing outcome data and use Rubin's rules to combine all of our estimates to get some idea of what things look like. Of course, multiple imputation is subject to certain assumptions. Missing not at random isn't helped by multiple imputation. So there we need to use something I've used in the past, a pattern mixture approaches. So thinking about how different those missing outcomes might be for those individuals who didn't respond and looking at what impact that has. So that's one way of looking at missing data. There are more advanced methods of dealing with missing data that are emerging to do with thinking about the causal questions that we're considering. And so I will name check Kate Lee and Margarita Moreno Betancourt at the Murdoch Children's Research Institute down the road who are doing fantastic work in this area. Dealing with missing data in cluster randomised trials, so here I'm talking about this individual level missing data, plenty of work to be done there. Plenty of work to be done. Thank you.
I think maybe we should cut it off there. Thank you for your questions. I'm just going to make one comment, though. I agree with you entirely on what you said about how wonderful it is to work with people who get up in the morning just to make the world better. But I think that also, you've demonstrated by what you've been saying, applies to statisticians too.
All of us.
So I'll ask you to thank Jess and Eugene.